started his Meta Academy, which is focusing towards the embryology training. Also, I would like to introduce Dr. Neharika Malhotra Bura. She is a MD Gynec, and she has also done in a diploma in advanced reproductive medicine from Germany, and also has won numerous Foxy Young Talent Research at AICUG and Foxy Kamini Rao Oration, to name a few. So with this short introduction, I will also try to introduce the topic of today, that is the cost-efficient management of upcoming IVF centers. As we know that buying power of the patients is going to be affected in a short term and maybe in a long term, and also the market size of IVF patient may shrink to some extent in this year and maybe in next year also. So looking at this thing, whether we can compromise in the cost or how we can calculate the cost more efficiently in order to maintain the delivery of the value in our IVF center. It is always said that remedy of the cost crisis does not require medical science breakthrough or technology, but it simply requires a new way to accurately measure the cost and compare them with the outcomes. So with this short introduction of the topic, I will first invite Dr. Narendra Malhotra to start the discussion on this topic, and then Dr. Keshav Malhotra will moderate this entire session, including ending with question and answers. So thank you very much for joining this webinar hosted by Shivani and Intas. Over to Dr. Keshav and then Dr. Narendra Malhotra.
Thank you, Ashishji, and thank you, Satpatiji, for this wonderful webinar. I think it's a very rare opportunity that all of us are actually doing a webinar together, and I would really thank both of you from the bottom of my heart to actually initiate this very interesting topic. So what we've done for today is we've tried to divide the webinar into 4 talks. We're going to start with cost-effective pre-evaluation of ART patients. Then we move on to monitoring of ART cycles and how we can reduce the cost in that particular genre. And then we move on to the stimulation protocols, and we move on to the lab in the end. So without further ado, I think I'd like to request Dr. Narendra Malhotra to take the stage and please continue with his presentation.
So very good noon to all of you. Welcome to these difficult COVID times, and welcome to this interesting webinar which we have lined up for you. Cost-effective evaluation of an infertile couple in COVID times, our protocol. And as you can see in the background, the world is full of COVID. All those dots are the countries which are having much and low. And in the foreground, you see the coronavirus, COVID attacking us, and we trying to defend ourselves. Sometimes we are scared, sometimes we are winning, and that is what COVID is all about. So COVID is a big boxing fight, which according to me, and it is the virus versus human. And on this side, the virus corner has millions and millions of virus. It has spread over more than 195 countries now, and only about 8 or 9 countries are left virus-free. On the human corner side, we are winning sometimes, we are losing sometimes. 5.5 million are affected, 60 million, 70%, sorry, not 60, more than that is lockdown, and 3.5 lakh human beings are dead. We brings you greetings from our Rainbow IVF, which is situated right here in Agra, and all those red dots are our partner centers where we offer technical collaboration, including Nepal, Dhaka, and teleconsultation to a center in Pakistan also. So let's see what the difference has it made to evaluation. Evaluation is going to be same, but in COVID times, something is going to be changed to make it more cost effective. We know about 80 million are infertile. We know that today 70% of world population is locked down. 90% of fertility clinics are closed, and they're opening gradually with strict guidelines. And the guidelines have been given by ESHRE, ASRM, Sper, ISRIFS, released yesterday, ICMR. They've already given us good practice guidelines also. And there have been also reports of spontaneous conceptions in the wait-listed ART cases. So that the unexplained infertility which was to be taken for ART or IVF has conceived on its own. The goal of every couple is to have a pregnancy, but this corona has put a temporary break on all the treatment modalities. Before I go on to testing, we should know when should we test. So when should we test is the age and the odds, and 86% of women will conceive in 12 months if they're aged 20 to 24. And only 52% if they are under 40, and over 40 is different. Now this forms the basis of active management and minimum testing of the patient. And the odds of trying reduces in 36 months, even in younger patients, to 3% per month. So you see, and at 40 to 0.5%. So 3 years, if they don't conceive, then on their own, they have a very, very less chance. That's why we call here is where we should intervene somewhere at 12 months. But in younger patients, in older women, we should probably intervene immediately, even after, as soon as they get married. If they get getting married late at 40, even after 3 months. So infertility, as the definition goes in 2006, is defined as failure to achieve pregnancy within 1 year of regular unprotected intercourse. And in COVID times, in April 2015, all treatments were suspended as per guidelines. Then ESHRE on 11th May said, patient management clinical recommendation said that we should gradually try to open up. And then the COVID-19 alert for patients in SAR says that the things can open up, but with proper precautions and minimum visits and minimum testing. Now, what does this minimum testing means? It means individualized to each patient in a unique situation. And we have the SARS-CoV toolkit, which you should refer, and we should be performing viral testing also in patients before they go in for investigation. So it's like choosing the right cost-effective intervention with traditional versus active management infertility. In 50% of the couples, you will not find a major cause even after a basic fertility workup. So that is where we need to make a cost-effective protocol for evaluation and management, or what we call as active management of infertility. Please remember, infertility is a two-patient disorder. The male and female both have to be thoroughly evaluated, and then a coordination of medical care to achieve the goal, which may be sometimes very difficult. So a detailed history, including additional history of COVID-related history, COVID-related consents, COVID-related declaration form by ESHRE, the 12-point form which you can download from the internet, a thorough examination and investigation, all less, except some clinics now will make test COVID for all. So the brief outline would be a history and physical examination, home monitoring of ovulation by BBT and informing us, one single progesterone, mid-cycle progesterone, mid-luteal phase progesterone to document ovulation, tubal testing, they have to come once for a HSG or sonosalpingograph, a semen analysis by yourself and not a detailed semen analysis, which I'll just try to explain, and of course the ovarian reserve. And depending on that, we will classify the infertility and go on to management. So our minimum management would be transvaginal semen analysis and a single day evaluation for the woman whenever she comes by a TVS, preferably in the follicular phase, so we can evaluate the tubal condition also. And this will categorize the patients of infertility and give a cost-effective investigation management protocol best suited for them. So let's see what we do. The couple comes to us, the first visit, when we are examining the woman by a per speculum and a TVS and a saline infusion sonography on the examination table. The man gives a sample and one drop of sample is put on a slide by yourself and examined yourself. So if you see a sample like this with rapidly motile, straight, almost all of them live, then a detailed semen analysis will offer nothing extra to the prognostication of the male factor. A detailed semen analysis tells you sperm concentration, mortality, morphology, and WHO classifies it has 15 million with 32% motile. The predictive value of individual semen analysis, the detail, is less robust when it is normal. When it is abnormal, then we need to go in for a detail. So despite of the limitations of a semen analysis routinely, we still have to do it to classify the patient into azoospermic, non-treatable, so they go in for donor or adoption, treatable disorder, rational therapy, optimization of the female reproductive tract and ART early. And if the semen analysis on the examination is normal, no therapy is needed to the male, and straight away we can go to the female. But if the semen parameters are abnormal, then we need to do a detailed history, physical, ultrasound, endocrine, karyotype, sperm function test, maybe testicular fine needle, testicular biopsy, post-ejaculation urine examination, and various sperm function tests which we do not need as the first step in all patients, only in abnormal. And where we should be testing the sperm DNA or DNA fragmentation is only to those patients who are offered IVF and ICSI with IUI failures. So unexplained 5 IUI failures, low fertilization, implantation failure, recurrent miscarriages, prolonged stay in an environment which is exposed to reproductive toxins, abnormal semen, and advanced age. And whatever method you do, Comet tunnel, sperm chromatin assay, or you do halo assay, whatever your lab does for it. So depending on a semen, look at the semen, we can say if it is normal, then you move away to the female. If it is abnormal, then they undergo a endocrine testing next. And depending on the endocrine testing, testosterone, LH and FSH, they're classified, and then the treatment of donor insemination, adoption, HMG therapy, GnRH therapy, pulsatile infusion, empirical therapies, IVF, or TDI and adoption can be for the abnormal sperms. And this chart can be seen by you everywhere, and we would like to follow this. So the take-home message for semen analysis is that conventional semen analysis, if normal, does not provide any more information than just saying it's normal. And there is no agreement on normal because the parameters are changing every day, and it is seen that patients with abnormal low sperm count also conceive on their own if given time. So in COVID times, the use of sperm function test is recommended only in IVF failures. Sperm function test may identify underlying male factor only if it is a very abnormal semen, and there is a need to accurately, cost-effectively target which patients will need advanced. So my advice would be only a single drop of covered slide by yourself, and if you see good motile sperms, nothing else to be done. And based on this, you can do whatever treatment which we want to do in the male. So this will summarize the whole of azoospermia, cryptozoospermia, severe oligospermia, mild oligospermia, and how they will go for IUI and which patients should be taken immediately for ICSI or IVF. So their time is not wasted, their unnecessary investigations are not done, and they take home a baby as soon. What about the female? Now 40% of infertility is because of purely female factors, and that too 60% is because of two factors, the tubal block 30 and ovulation factors 30 approximately. And 10% of cervical, 10% of about couple problems, and about 20% where we cannot find a cause unless we do an IVF, so fertilization failures. So the basic investigation on the first visit, whichever day she comes, is a detailed history, COVID-related history and COVID-related consent and COVID-related forms to be signed, a physical examination for androgenic and estrogenic features, and of course a per speculum examination and any day ultrasound to rule out treatable causes and to see whether ovulatory factors. And then at the same time, we put in a small Foley's on that table, on the ultrasound table, inject some saline and do a saline sonography and a tubal patency. So that's how we do it. So the list of investigation is long, but RCOG and ASRM consensus say there is a set of basic testing. and the RCOG and ASRM consensus of advanced testing. But they say the advanced testing does not improve the pregnancy rate. So all women, irrespectively, as we see a lot of people do, hand over a huge list of investigation. Get this done and then come. So the investigation only costs them some 25,000-30,000 rupees. I think that is not justifiable, and a laparoscopy done to all of them is not justifiable, and a hysteroscopy done to all of them is not justifiable. So we do only the basic investigation, especially more rely on basic investigation in these difficult times. And the RCOG guidelines says the basic is on the male side is semen analysis, on the female side evaluation of tubes and evaluation of ovulation. So mid-luteal progesterone, we do it by ultrasound now and by HSG. ASRM also says similar and says some positive cases, those who are showing there. And a good ESHRE task force says semen analysis, tubal ovulation. If not, then postcoital anti-sperm antibodies and zona-free hamster pellet. And if not, the third level, which we rarely go up to second and third level only for evaluation. So for me, especially in these times, level 1, semen analysis, tubal patency, ovulation by ultrasound only, no hormone analysis is good enough for me, except for thyroid and prolactin in both of them. So thyroid, prolactin, and then we form a beautiful algorithm on how we'll manage these patients. So our protocol at our hospital is, the patient may come walk in any day. If she takes an appointment, we try to call her on post-menstrual, so early follicular phase. But if she turns up on day 2 or day 3 or follicular or luteal phase, then we divide them into age, young age and lesser duration of infertility, less than 5 years. Younger but married for a longer time, more than 5 years. And over 34 with less than 10 years or more than 10 years of infertility. And over 40, they will obviously be more than 10, but some people may be married only at 40 or 3 or 4 months. So they will have a different set of counseling and a different set of investigation, which will lead them to straight away to ART. So we evaluate by ultrasound, and by ultrasound we evaluate for ovarian cysts, for PCOS, for hydrosalpinges, for endometriosis, for polyps, for fibroids, for irregular endometrial shedding, and we put in a Foley's tube, Foley's catheter, or a feeding tube and do a saline sonosalpingography or saline sonohysterography immediately on the day 1. So the color tells us the endometrial vascularization. SIS tells us the polyps, where they are, or fibroids. Color flow tells us the tubal patency or tubal bruise, sonosalpingography. A Foley's inside inflating tells us about the cavity. And when I do a color uterine artery Doppler, it tells me whether the blood supply is according to the cycle or not according to the cycle. So she's getting good blood flow or not. So my investigation would complete only by this on one shot on one day. So I will see 30% blood flow in the uterine artery compared to systolic, the rule of 30 in a non-pregnant early follicular phase, and I'll try to see follicular endometrial synchrony by growth and by color both. And the early follicular phase, no diastolic blood flow increases, and by the time follicle is about to rupture, the diastolic blood flow in the uterine goes up to about 40%. So the resistant index would be about 60%. And when we look at color power in the follicular phase, early follicular phase, the blood flow spiral arteries at the edge, and then as they go inside, or zone 2 and zone 3, and then finally to zone 4. And that completes my investigation that this woman has no other problems. So if something is abnormal in this, that means there is fibroid, endometrioma, PCO, then accordingly we'll treat them medically or surgically, or they go for IVF. But all patients are not subjected to laparoscopy, which is too much of. How do we evaluate the uterus? I told you, by putting saline, doing a 2D, 3D, or by HSG. HSG I would like to do if I'm doing it myself or my team is doing it, and I will not like to refer the patient for an HSG to a radiology center which might be having so many of chest cases this time and so much risk of COVID being spread or being caught. So during these times, do it yourself. It is going to be your motto, and do the tubal testing yourself. And it's very simple to, instead of HSG, sonosalpingography, saline sonohysterography for polyps, hydrosalpinx here you can see, pre-patency you can see here. Here you see the spill is only in, and that hydrosalpinx is increasing when I'm pushing the saline. So it's a fimbrial block. And it's very, very easy to do, and no need to go and further do MRIs and things like that. Laparoscopy for me is only in positive cases and not in all 100% of the cases. Only when I see endometriosis, I see fibroids, or I see any problem, then they go in for laparoscopy. Otherwise, the diagnosis is all made on day one on ultrasound based, and then they are subjected. Only some of the cases of unexplained infertility and failed IUI, which have these type of lesions, Allen-Master syndrome here, or these type of lesions, they cannot be seen by ultrasound. And these are the patients who will benefit by a laparoscopy. So laparoscopy will be for unexplained infertility where ultrasound is negative, does not find any problem, only after 3 failed IUIs, not before that. HSG is good, but if you do it yourself. Sonosalpingography is much better because you're doing it here, especially in COVID times, where the patient does not have to go to the center, radiology centers to get exposed. So then we will do this. And if we are going to do endoscopy, it's always going to be double or triple puncture, and it's always going to be accompanied or preceded by a hysteroscopy. So we might miss adhesions like this, even sometimes by ultrasound, then this can be simply treated, which is a block at the, as you can see, at the cervical, and you just open up the cavity and that's it, and the patient gets treated. How about ovarian reserve? Ovarian reserve is very, very important. It declines, again, a very important test. And previously it used to be done by FSH and antral follicle, but today it is AMH and antral follicle count. And in COVID times, it's only antral follicle count. So age of the patient, antral follicle count, if possible, and she has come to the center, AMH can be taken. So if the patient is young and has a poor antral follicle count, less, like in this picture, the gray one, she has better chances of pregnancy than the antral follicle count more and the age of 40. So age is a predictor of pregnancy. Antral follicle count is a predictor of follicles and eggs, and AMH is also. So antral follicle in AMH, if you're good with ultrasound, antral follicle count is much better because AMH standardization of laboratories is not very sure. So different laboratories may give a different unstandardized report, and that would be a problem. So ovarian reserve testing, do it yourself again on the day when she comes by doing a good AFC and a color Doppler. So otherwise it can be done biologically, as I told you, age, by testing AMH, by doing some dynamic tests which are not done now, which is GAST and CC challenge test, by biophysical, which is the best, and which is ultrasound. Do it yourself, count the follicles, do a ovarian volume, do ovarian blood flow, that's it, and you get a good response. But the patients in these difficult times can also do ovulation testing or at their home by LH kit, or by giving blood in the mid-luteal phase, or by doing the postcoital test is in level 2 according to the ESHRE and ESRM, and it is not done these days except for where the man is absolutely refusing to give us semen samples. So that's only indication which we are using. For all females and males, a thyroid and prolactin probably is a routine and a must examination because of the thyroid factors and prolactin being high will cause infertility in both of them. So based on this, we can devise an algorithm on and go in on management. And based on this, we can classify the infertile couples, whether they are single defect or multiple defect. And if they are multiple defect, they go straight for ART, no more wasting time. If they are single defect, correctable defect or not correctable defect. Correctable defect, corrected, pregnant. Not correctable defect, give a trial, does not conceive, go for ART. And if it is no defect, then no further investigations, only routine investigation and pregnancy will occur with expectant management. If it does not occur, ART. Or you give no defect, you give some superovulation and IUI, and pregnancy may occur. If it does not occur, go for ART. So this is how the infertile couple would find it easy with minimum testing and early. So single defect, half of it will conceive, half will not with treatment, and they go for ART. Multiple defects, early ART. As soon as we know multiple defects, do not waste our time on any other further investigation, take her for ART. And no defect, expected treatment if young, laparoscopy, hysteroscopy if they are around 35, and if they're over 40, straight away do ART. So again, this would treat you. So the management protocol will be decided according to this, whether medical, surgical, or ART. And then we should know which will get pregnant. So the favorable patients will be less than 35 for Indians, 37 Western, less than 7 years, basal FSH less, no lump, ovulating. Unfavorable will be older and going towards ovarian failure, distorted pelvic anatomy, other things, adhesions and all. And again, this group will respond to medical treatment, the favorable group, and will succeed. And the unfavorable group should be taken away straight for ART, and no time should be wasted. So ladies and gentlemen, to conclude, evaluation of a disease will help the clinician, especially so in COVID times, to decide on ART treatment early, and to give, our basic aim is to give the patient a baby, a take-home baby. And the most effective way of evaluating is a single day testing by TVS in your own clinic, by yourself, in the first visit, with or without saline infusion. We don't do saline infusion in secretory phase for tubal testing, but we can do. And this would then chart your patient to whether IUI or ART immediately, and will save the time. So different angles, different viewpoints, evaluation should be individualized. Avoid unnecessary testing, avoid laparoscopy and hysteroscopy for all. If I do it for all, every infertile patient who walks in, only 15% will show some peritoneal factors. Others would have been diagnosed by ultrasound. So the aim is not to waste patients' time, patients' money, and patients' resources. I thank you very much, and I'm sure that we are going to win over COVID and do social distancing in labs and have minimum interactions, and will take full precautions in handling IVF cases in the future. Thank you very much for giving me this opportunities to speak to all of you. Thank you, Dr. Keshav.
So thank you, Dr. Narendra, for that wonderful lecture. And I'd like Dr. Neharika to load her presentation in the meantime. Now, we know that selection of the patient is very, very important. And that's what Dr. Narendra has mentioned here, because if you select your patient properly and avoid the amount of tests that you're doing on the patient, you will be able to actually offer cost-effective solutions for the patient, because these are challenging times. Patients also don't have money. They want to conserve their resources. And these are things that we want to think about now. Now, the next part of this webinar is going to be actually the monitoring part. Where can we cut down the costs? How can we cut down the cost during the monitoring of the patient when the patient is undergoing an ART cycle? So over to you, Dr. Neharika, for this presentation.
Good afternoon, everyone, and I welcome you to the first ever Malhotra webinar, where all four of us are doing this webinar together. And I'm going to concentrate on cutting down the cost during the monitoring of your ART cycles. It's not just about cutting down the cost, we also have to cut down the exposure. So when we talk about what are exactly the main hurdles for advanced treatment of infertility, we know that three important hurdles are, one of them social, then of course expertise, and the most important in our scenario is financial. But now another hurdle has come up to us, and that is the COVID-19. Subfertility is actually a very global health issue. But in developing countries like ours, we know that our resources are not directly channelized into non-life threatening conditions like subfertility, and it is not on our priority list. But we also have to understand that subfertile couples not only bear the sorrow of not having a child, but they're also subjected to a lot of social stigma. Now, during this COVID time, the stigma, the fear is increasing. Though the pandemic is now stabilizing and we are slowly trying to return to our normal life, and we have to now restart the ART treatment. But before starting any center, we have to understand first is a good discussion, an agreement, and also a consent to start the treatment. We have to get in place our staff and patient triaging, access to advice and treatment, adaptation of the ART services during this pandemic, and planning your treatment cycle, and of course, the code of conduct of the staff and the patients together. So this quote was in the ESHRE guidelines of 2020. It says that who sees all beings in his own self, and his own self in all beings loses fear. So before starting any ART practice, we have to understand that, do I want to get infected? Ask yourself this question: what should I do in my clinic to avoid COVID-19? Am I responsible for others' health? We have to also focus that safety of doctors, staff, and patients, all three of them have to go hand in hand during these times. Any normal ART cycle follows these steps which we see. We go from an investigation to ultrasound to stimulation, ovum pickup, then an IVF and an ICSI cycle, embryo transfer, blastocyst culture, luteal support, and pregnancy follow-up. Then we come to the most important aspect is monitoring of an ART cycle. Why are we focusing so much about monitoring? And why do we need to actually monitor an ART cycle? Two important points. First, to make our procedure more efficient. And second is, of course, to reduce the complications associated with treatment. Then comes monitoring during this pandemic. So during this pandemic, we have to understand that the aims of monitoring, which we discussed were, we also have to add to it is that minimal exposure of staff and patients. Isolation of any staff, it has to be understood that even if your staff has some symptoms, that staff has to be isolated. You have to provide personal protective equipment to all your staff and healthcare workers. You have to have minimal number of visits. Proper vaginal probe hygiene has to be followed. And it's not just triaging once, but you have to keep re-triaging your staff and healthcare personnel. A lot of guidelines have now been come from government, from international bodies, and also with these guidelines, you have to combine your local personal needs. So the most important guideline which came in ART practice was the BMC guidelines. And these BMC guidelines actually divided the patient based on your female age, your ovarian reserve, and your previous history, and then classified them into a Poseidon group. And then they thought of that the group which is important and which cannot wait for this pandemic to get over should be treated first, because they have a distinct prognosis concern in conceiving. And that's what these guidelines came in being. The second thing which once you start your ART treatment is to triage your patient. First, we did a triaging of our staff. Now we have to decide to triage our patient. So triaging is simple. A 12 to 15 questionnaire is provided by almost all the guidelines. And this triaging can actually be done on the phone. So once you've given a triaging questionnaire, you do it at least 2 weeks prior to the ART treatment which you're starting. And then you divide your patients into 3 scenarios. That is scenario 1, where there's triaging negative and you have no history of any suspicion, or the patient is not residing in any orange or red zones, patient is in a green zone. Then this patient can be followed up for a ART treatment. So call them on day 2 of the cycle, do another triaging again, and follow the standard procedure. The second triaging is on the orange zone or a questionable zone. So now you've understood that this patient has some suspicion of getting SARS-CoV or stays in a hot spot, or has a history of travel or contact. You would like to do a COVID test before starting the treatment. But we have to understand, even if you do a COVID test before starting of treatment, the patient can get COVID during any time of the cycle. So ideally, in these cases, we should do a COVID test twice, that is once before starting the treatment and once on the day of HCG. And we also should provide them with a full consent of cycle cancellation if they develop COVID during the procedure. The third scenario is the red scenario, in which that the triaging comes positive and these cases are actually directly postponed. Now, once you've decided that in this pandemic we have to do an ART cycle, we also have to focus on attempts to decrease the cost plus the exposure. So where does the cost of an IVF treatment lies? The first step is the main IVF and ICSI cycle. The second step is the medicines and the injections. And the third one is the investigations and monitoring. So whenever you actually decide to start, you from the beginning, you have to have fixed protocols and SOPs and staff training. You have to actually target all individuals entering the clinic. It's not just the patients, but all the healthcare workers, doctors, and staff. There has to be a proper written consent whenever you plan to start an ART cycle, and then there has to be a stepwise guide which you follow, or a stepwise protocol of your clinic. So ESHRE guidelines which have come up right now does tell us about proper social distancing, how to clean and sanitize your labs. There has to be a separate in and out of the clinic, and of course respecting the triaging rules which are there. So when we plan to monitor the cycle, we have to also limit the time the patient spends in our clinic. So the first visit can actually be a teleconsultation. Teleconsultation has a lot of advantages. The time taken by a normal history taking is actually can be done through teleconsultation, and you can limit the exposure of the patient sitting in your clinic by at least an hour. So the first visit can be done at 2 weeks prior to the period date, or at the time of day 21 of the cycle, where you take a good history through teleconsultation. You advise them with a broad spectrum antibiotics. You can also give them a basic routine investigations which they can go and get it done from their laboratories which are near to them, and send them on WhatsApp or email. You can do the self triaging on the phone. You give them that questionnaire and let them answer those questions and send it back to you. And an audio and a video consent regarding COVID and explanation can also be done during this time. Then once you plan to start the cycle, you decide how we normally routines ART cycles are monitored are by an hormonal level, an ultrasound, or combined. So, and when do you actually monitor? You monitor them on a day 2. Then you actually call them between any time between day 5 to day 9, and then a day trigger. So during a routine ovarian stimulation cycle, normally people would like to call them at least 3 times before you plan a trigger. But in these cases, when we are thinking of COVID times, we are minimizing the exposure, we can actually decrease one visit. That is, in a patient which is a normal responder, has normal cycles, you can call them on a day 2, do a good ultrasound. You need not do the hormonal evaluation if the ultrasound is normal, and then start them on a basic dosage, and then directly call them on day 9. But if there are patients like poor responders, or in patients like PCO, then you would like to call them on a day 6 and then again on day 9. So on day 2, when I call my patients, I would not like to do any hormonal evaluation like E2 and P4. TSH prolactin, we had already advised them before they had reached to us. AMH, a yes, because it's good for documentation. Ultrasound for an antral follicle count and other pathologies, a yes. A cervical culture is questionable. We in our clinic do not follow the cervical culture. We actually like to give them a broad spectrum antibiotic coverage. This is actually a personal choice. A lot of guidelines have now come between 2017 to 19, which do tell us that there is no need to do a cervical culture in patients. So on a day 2, a good ultrasound scan is the most important thing. And in this scan, what you actually have to do is you have to exclude any residual cyst which can be seen. You have to assess the cavity, you have to assess the pelvis, and then you fast track them if they need any surgery, or they have to directly go into an IVF cycle. The second thing, if in some cases you would want to do an E2P4, then it is like if you see a cyst like this in my last picture and with a thin endometrium, then maybe you would like to do a estrogen levels. If you see thickened endometrium in the second picture, or even in the first picture, if you see endometrium like this, I would like to postpone this cycle instead of doing any procedures right now in this pandemic time. So we have done a day 2 evaluation. We know what to do in that. Now we come to a day 6 evaluation. Mainly a day 6 evaluation is done in cases to assess the follicle response to your gonadotropins. So ideally on this day, what you would see is at least 3 to 4 follicles of more than 10 to 12 mm and a basic triple line endometrium of about 6 mm. If you see this, then the dose which you have given is correct and there is no need for any dose adjustment. The next step which comes is a day 8 or a day 9 evaluation. This is an important step and this has to be done in all. It is now time to decide the timing of your trigger. And so if you see at least 3 follicles of more than 17 mm and you see an endometrium which is triple line with a good blood flow, you can now decide to give trigger tomorrow, like in this picture seen. So here you see a good blood flow in the endometrium, a triple line pattern, and you see 3 to more follicles which are more than 17 mm. So in my case, I would like to give this patient a trigger tomorrow. Coming to the monitoring by hormones. So most routine hormones which we monitor are by estrogen or progesterone, but we can actually go without them if we are doing a good ultrasound scan. So a day 2 or a day 6 estrogen level is not actually very necessary. Only needed a day 6 estrogen is when you are actually suspecting OHSS, or when you are not calling the patient on day 6 and you want to know that your dose was correct, then maybe you would like to tell them that get a estrogen level done from a lab near to them and send us the report. And if the estrogen level is less than 150 to 200, maybe a dose adjustment might be needed. So this was when we were monitoring the stimulation cycles. Then we come to monitoring a frozen embryo transfer cycle. So mainly day 2 E2P4 estimation if the patient is not coming to your clinic, and then start on the estrogens and directly call them on day 12, or you do a day 2 ultrasound, then you need not do estrogen and progesterone and call them for an evaluation of endometrium or day 12. So important 3 parameters while we want to assess the endometrium is, the first is your endometrial thickness, which has to be at least more than 6 mm and less than 13 mm ideally. A good endometrial thickness should be anything between 7 to 10 mm. The second thing is a good endometrial pattern, and the third is a endometrial blood flow. So we as infertility specialists have to actually evaluate these 3 important parameters when we are doing the scans ourselves. So how should a endometrium look like when you call them on day 10 or day 12? So this is a beautiful picture showing a good triple line endometrium, which is more than 6 mm. And you can actually see the proper leaf-like pattern. And this is also a good grade AB morphological pattern. When you're measuring the endometrium on day 10, sometimes you also may see some kind of fluid. So a right measurement of the endometrium is also important. So if you see any amount of fluid, which can also be cervical mucus, you need to measure the endometrium twice, that is on wherever the endometrium layers are seeing, and then do the total of that. And that total is taken as your endometrial thickness. Right measurement of the endometrium is one of the most important factors which will determine the success of your embryo transfer. If you can do a 3D, 4D evaluation, do it yourself, because in many studies by Kurjak et al., it is said if a volume of your uterine cavity is between 3 to 5 cc, it shows that the uterus had good receptivity. The last parameter during a frozen embryo transfer cycle is we would like to see is uterine perfusion. So we all understand the blood flow of the uterus, and we know that the uterine artery changes stepwise during your menstrual cycle. We also know, and a lot of studies have been published, and they do say an increased blood resistance blood flow in the uterine arteries is shown to have poor implantation rate and poor pregnancy rates. So a good color Doppler of the uterus with that endometrial thickness to be done on day 12 is of utmost importance, because in your frozen embryo transfer cycle, you are now calling the patient only twice. That was one was on day 2 and one was day 12. And then again, the patient will come only for the embryo transfer. Uterine artery perfusion also depends on the patient's age. So if the patient is more than 35 years of age, then you would like to assess the uterine artery perfusion carefully. of course, with the phases of menstrual cycle, and it also has a complex relationship between your ovarian hormones and uterine artery blood flow. After a uterine artery perfusion, we watch for subendometrial blood flow. And a lot of studies have supported us in saying that an absent subendometrial or intraendometrial vascularization is a predictor of failure of implantation. So what happened was Michael Applebaum studied the endometrium, and then he divided the endometrium into 4 zones. As you can see here, zone 1, zone 2, zone 3 and 4. And then he studied the blood flow in all these 4 zones, and then he correlated this with the pregnancy rates and implantation rates. And he found out that if there was no blood flow in zone 3 and 4, then no pregnancies actually happened. So this is how the blood flow on an ultrasound on all 4 zones look like. And what you would like to have is this image or this image before the embryo transfer. That is the lower 2 images on this picture. The last evaluation which we do is a progesterone measurement. We in our labs actually do not follow doing a progesterone measurement, but in some places where you have a doubt, you can do a progesterone measurement if you want to. And we do know that serum progesterone, if it is more than 1.5 on the day of trigger, is associated with lower pregnancy rates, and it is also directly affects your endometrial receptivity. So in cases where you are not sure of your ultrasound scans and you have any doubt, you would like to do a serum progesterone level. Then the last point during this monitoring is cycle cancellation, a decision, or a freeze all decision. In India, we cannot actually afford to do a cycle cancellation because these patients pay by themselves. So our main aim is to not to have a cycle cancellation at any cost. But during the pandemic times, we have understood and we have counseled them that in case they come positive with COVID, they might have to have cycle cancellation. Other reasons for a freeze all strategy can be prevention for OHSS. And if you see prevention of OHSS, the second thing is if they come COVID positive anytime during their cycle and you are predicting OHSS, then you might not want to cancel the cycle. So what you can do is you can post them for a pickup, but with full precautions, with full PPE kits for all the healthcare workers, and you freeze those eggs separately and maybe sanitize the lab after that. So that can also be done. So now in the end, we come to how and where can we reduce the cost of an IVF cycle during this monitoring. The first most important step is we have to do is a careful patient selection. So we need not offer unnecessary IVF, but we also need to understand that we need not waste the time by doing multiple IUIs instead of doing IVF when they're actually needed. So a good patient selection will reduce the cost of IVF. Then simplifying the investigative methods. You need not test all patients for a RPL panel. You need not do all those sperm tests which we discussed in the previous talk for all patients. Then reducing the cost during your ovarian stimulation, which will come in our next talk. So that also makes an important point where you can reduce and strategize in your IVF cycles. Simplifying the procedures and equipments in your laboratory. And of course, very important is minimizing the complications of IVF. Because when we talk of IVF, we know there are direct costs, there is an indirect cost, and there is one downstream cost. And this downstream cost is OHSS or multiple pregnancies. And that has to be understood. We are an OHSS-free clinic, and we would prefer a single healthy baby child instead of multiple pregnancies. So when you go through your clinic, you see all these following heads and you understand the cost can be broken down through these heads like clinical fees, consultation, ultrasound monitoring. Then there is medication cost, then investigations, then of course, whatever happens in the theater, ovum pickup, embryo transfer, any cyst aspiration, and then the laboratory cost. So once you calculate all these costs, you can understand where you can actually cut down the cost. So my last few slides are on the guidelines which tell us that can ultrasound alone be used safely. So when we talk about that, we do not want to monitor them with hormonal levels. We're going to limit the exposure of patient coming to the clinic Then can ultrasound be safely used? It is a big yes, and a Cochrane study was published in February 2020, and they did compared six RCTs, and they showed that there was no difference between doing a monitoring of an ART cycle alone with an ultrasound or monitoring them with ultrasound with hormonal levels. So if you are good and you're doing your scans yourself, an ultrasound is the mainstay for monitoring. What does ESHRE also say is that a single ultrasound assessment is actually necessary to identify the patient. So a good day 2 scan will actually tell us what appropriate diagnostic workup this patient needs, what kind of protocol this patient needs. And they also tell us that estradiol levels are not needed to decide a trigger. So my take home points during this pandemic with IVF is that we have to limit the face-to-face visits by an infertile patient. We have to have proper regulatory infection prevention recommendations. The training of the ART staff is of utmost important. Follow good standard laboratory practices and do a good thorough discussion of your patient with your doctor, and then make a decision of going ahead with an ART cycle. So I conclude by saying, as doctors, our aim is to provide an affordable ART program in our developing country. Modification of the traditional protocols and a monitoring system will help in reducing the cost and exposure of the patient. Thank you.
Thank you, Neharika, for that wonderful presentation. We have lots of questions for you, and I think we'll be taking them in the discussion. So our next speaker is Dr. Jaideep Malhotra, and she's going to be talking on how to minimize cost during stimulation. So Dr. Jaideep, if you can unmute yourself and share your screen, we are ready to begin.
Hi, a very happy Sunday to all of you. Thank you, Keshav, and thank you, Intas, Dr. Ashish Modi and Mr. Satpathy for this wonderful opportunity for the family to be together. And I hope with all of you there, I can see loads and loads of people. I'm sure your time will be well invested. Today, this corona has actually affected our lives almost 360 degrees. And we are really, juggling with a lot of things at home, in the clinics, and it's just a very fairly recent infection. Every day, our understanding is changing. I was just going through in this last corona, 2 months, 23,000 publications have come. Now, if we go on like this, I don't know where we are going to reach, but yes, keeping track is very, very important, because that is how we are going to actually learn. Now, I feel that it has been a great, opportunity for us to actually sit down, understand and relax, and then work our brains on that how we're going to modify our practices. Because one thing we have to understand is that this disease is here to stay. And also we cannot just shut ourselves up in our houses, and the patients also cannot be just left alone to fend for themselves, because there are quite a few people who actually require our services and are also losing out on a lot of time. So we need to resume work, but we need to also resume work with the new normal, which has been discussed a number of times. And I want to congratulate ISAR, IFS and ACE also for bringing out guidelines on how to resume work. We also need to understand that, yes, our practices and our protocols will have to be modified. And one thing I think all of us have understood is that telemedicine and teleconsultation or telehealth is the new norm, because this is something where you are going to prevent or minimize the interaction between the patient and the doctor, between other patients, and also minimize the spread of the disease. Now, when we start, I've just put 2-3 slides here just to tell you that whatever we are doing today, the information to the patient is very, very important. So we really need to signpost every current development in the clinic, and take a consent from the patient that this is what the clinic's policy is and this is what we are going to do, and that is very, very important. So this documentation is important. You prepare all the documents, send them before they come to you on any of the digital platforms for your teleconsultation, and all they can do is sign the document and then take an appointment, which is very important, because all elements of whatever you're doing in the clinic, they need to be discussed with the patient thoroughly, because in these times with so many challenges, I don't think we want any other challenge of a litigation or stress given by litigation. Second important thing is that we are very worried. I've been talking to a lot of people, and they're, there's no work and what are we going to do? I feel no work is better than work which will jeopardize your reputation, jeopardize your systems, your staff, and we have responsibility towards everyone. So we are the ones who will actually have to maintain a lot of protocols as far as the resumption of services are concerned. And triaging, as Neharika had said, triaging your staff and also educating your staff is very, very important. Now, let us now come to, I'm going to talk on smart ovulation, because it is very important for us to understand. We do a lot of stimulation protocols. It is beyond the scope of this talk for me to discuss each and every protocol. But I'm going to just tell you that, yes, we need a few protocols which have to be applied at the right time, at the right person to get the optimum result, and also cut down on the cost. And those are the ones which are very important. Now, who are the people who should be taken in the first place? Because right now we are juggling. Should we start IVF? Should we start stimulation? Or no, some of us have started with the frozen embryo transfers, because embryos are frozen and these patients don't really need too much of investigations, and you can actually do a transfer in the natural cycle or a natural modified cycle. So basically, people who are losing out on time, like advanced maternal age, or especially ones who need fertility preservation, or the ones who are really upset that they're wasting a lot of time, are the ones which need to be included. And we definitely have to exclude couples who are symptomatic or have tested positive or are liable to have complications, because complications is the last thing we want, especially at this time. And that's very, very important take-home message. So you can take your chances, but you should not take a chance where even 1% chance is there for this patient to have any kind of complication. So prioritizing is important, and nobody can teach you prioritizing. You yourself, according to your team and the availability and the infrastructure and the training of your team, are the person who will actually gauge what you are capable of. So that's one of the most important messages I would like to make everyone understand. So prioritizing is important, but prioritizing at what cost? That is the most important message which should be there. Now, there are certain group of patients whom you can immediately close your eyes and delay them. There's no need for us to take any risk for them, especially, we like severe asthma, poorly controlled diabetes, chronic lung diseases, severe obesity or kidney disease and all. You don't have to take them at all. Or the ones where you have unknown risks of vertical transmission and the patient is also not understanding. Don't take a blind consent, because if you take a blind consent and if the patient lands up in some problem, a lot of investigations are happening. Even if a patient becomes COVID positive, then you will have to need to do the explaining, why did you actually take this patient up? And that's very important again for us to understand. A COVID test is a must, not only for the patient, but also for safeguarding yourself and your staff. And that is important. We can debate on it, that how many times you should do, but at least one time before, I would say giving HCG trigger is the time when at least we should do. Now, whatever we may do, we are trying to cut down on cost, but we have also added up a lot of costs, especially the cost of care has gone up. the cost of personnel has gone up, the cost of technology, artificial intelligence, disposables is going to go up, infection prevention and control is going up, additional compensation to the staff and the workers, insurance, lockdown, like, I mean, unbelievable, developing the systems, trainings and protocols, all costs are going up. So how can you now reduce the cost? Now, somewhere we need to have a compromise here, and there are areas where we can cut down, and that is exactly what we have discussed in the previous two talks and in investigations and monitoring. And today we will discuss on how we can do it in our stimulation protocols also. So let us now understand. The first and the foremost thing for us to understand in individualizing protocols is that today there is, I think, very limited role of conventional protocols. Initially, we used to talk, individualized protocols. Yes, this is the time when we most importantly need them. So adopt a personal ovarian stimulation protocol, which is based on not only AMH and antral follicle, but on many other things. Where is the couple coming from? What is the age? What are the problems? What is the ovarian reserve like? Whether they will be able to come, for in between checks or no. There are loads and loads of things, and what are they capable of paying also, which is important. Try to do a fixed dose gonadotropin protocol, because this is important. That the day 6 where we were actually trying to call the patient and assess and then change or modify, as it is, there is enough literature to tell us that if you start a patient on a particular dose and if you have continued on the same dose till the day of HCG, these patients have the best outcome. So we need to actually make an initial good assessment on the dose, starting dose, and hopefully we should be able to continue that. Antagonist protocol is the dictum. Now, fixed antagonist or flexible antagonist. Now, normally all of us practice flexible antagonist protocol, but here, especially in patients where you have had a normal regular cycle, I think a fixed antagonist protocol can also work. So now you need to individualize that this patient I can give a fixed antagonist protocol. This patient, like especially PCOS, or where you need some more interaction and monitoring, they can be kept for a flexible antagonist protocol. Now, agonist trigger or a dual trigger now, or an HCG trigger. Those are the ones which, again, trigger is important, and there again you have to individualize and see which are the ones who will be suitable for agonist trigger, especially all frozen cycles. Close your eyes and agonist trigger. Where you are in a dilemma where you think, okay, if the number of eggs are not too much, if I don't have to freeze, because freezing also, what we are recommending, and I know that Keshav will talk about it, is that we are also right now propagating that whatever embryos or oocytes, your sperms you are freezing, you have to keep them separate. You should not mix them with your already existing pool of embryos or eggs, and that is why the load of having separate cryo cans and all will also increase. So, but if you are having one, then yes, you can think about it. But dual protocol is where you could probably have a little dilemma in deciding, depending upon the response. And HCG you can anyway give to all poor responders and the ones normal responders who have not had a very huge response. Now, freeze all or fresh transfer again has to be, you have to talk to the patient and then to your team and then make a decision. And all this, mind you, can also be done on teleconsultation, which is important because you have to, decrease the interaction with the patient. No matter whether you are wearing all kinds of personal protection equipment or your staff is wearing, the interaction has to be reduced. And that's important. Very few clinics are actually, doing fertility preservation, so they have their own protocols. But for poor responders, we normally used to say a dual stimulation strategy. But here I might not, because again, it all depends on what the patient is in for, whether the patient is coming from far away and staying here, and that is a time maybe I will do a dual stimulation for them. So everything, whatever you know about has to be consciously, intelligently put into a protocol which is individual for that particular patient. Now, what is important for the patient? Patient is really considered only taking a baby home. Now, in the view of taking a baby home, the patient needs right now, how much time will I spend, what will be the result, and what will be the cost. Now, there are three important components which we need to understand and also try to give the baby to the couple, which is important. Now, ESHRE on 1st of May came out with these guidelines. Now, we should read everything. I don't say that, we should not read them, but once we read them, we cannot apply the same guidelines in our scenario. This is something which I want everyone to understand, because our scenario is totally different. In our scenario, our patients pay for themselves. The affordability of the treatment is very much varied in patients. Our treatment may vary from tier 1 to tier 2 to tier 3 cities, and that is something which we need to understand. And that's why I am telling you that not only today, yesterday also and tomorrow also, individualized protocols are the ones which will be there for all of us. So what does ESHRE say? For low responders, you could do a GnRH antagonist protocol or an agonist protocol, and the dose is between 150 to 300. Okay, it's not a very small dose. For a normal responder, again, you can do an antagonist protocol or an agonist protocol. The dose is between 150 to 225. And for a high responder, the dose is again antagonist protocol and about 150. So now this is with a little understanding. I'm going to now go further and say that right now, it's like a turning point in our understanding. So we need to now weigh between change and chance. Now, should we take change is inevitable. I don't see any reason for us to understand that we have to change. We have to change, and that's for there to stay with us. But chance, should we take a chance or no? So I would say that whenever you take a chance on a calculated risk, which is important, because this chance should not be taken that, okay, dekha jayega jo bhi hoga, because it is not what is really expected out of us at that point of time, and accountability is increasing. So now what do I do to assess and decide on a ovarian stimulation protocol? There are many things which I have put in here, which are the factors which are really affecting the stimulation protocols. But I would say here that even when we are based on all those factors, is there an ideal stimulation protocol? The answer is no. So how do we really individualize now these stimulation protocols, which are really important? Now, we need to have a very cost-effective controlled ovarian stimulation protocol. Now, when we do that, there was a lot of debate which has been happening. I have put in a lot of articles here. One thing which has come out with all these articles is that when you individualize protocols based on the ovarian reserve test, they actually have not improved the live birth rate or have reduced the cost, but they have definitely increased the safety and effectiveness. Aren't we really looking for that right now also? And that is something which we have to, take a call on. Then there also have been that whether these studies which I have put in here, whether we should do a fixed dose or an individualized dose. Now, again, there have been number of studies which actually have said that, ovarian reserve testing and subsequent dose adjustments are justified, and basically a normal responder, we will respond to, let's say, a normal adequate dose between 150 to, let's say, 225, or maybe 150 is something which is there. The problem is between the poor responders, because there are many studies and many of us are very, very adept at just putting the poor responder at a high dose, anything between 300 to 600 international units of either FSH or HMG. Now, enough number of studies are there which say that poor responders actually do not benefit from all those high doses. So there's absolutely no need for us to put them on those high doses, but definitely higher responders do benefit as far as safety and cost is concerned, and not compromising on the live birth rate on reduction of dose of gonadotropics which we give. So I think we are very clear on this. And what we need to also understand is that the sequelae of this high ovarian stimulation, because there are consequences which are there for luteal phase problems. The endometrial receptivity goes for a toss with higher doses, and also chances of embryo aneuploidy are also pretty much higher, though we normally don't bother, but they translate into early miscarriages or implantation failure in our cases, and that is something which we should also look into when we are analyzing our results. So milder stimulation protocols is the dictum today, because it increases the safety, it reduces the cost, and it definitely gives a more better embryos and a better physiological scenario. Now, how do we really predict a response? So there have been a lot of these algorithms which are available to us. I don't know how many of us actually use it, but this one I have just put in, which is based on the age, on the AMH and the FSH status, and where this dosogram actually tells you what dose of FSH to start. Now, it is very simple and you can easily do it. But even if we go with a normal this thing, today we do understand that on a normal or an average reserve, antagonist protocol and a milder dose is something which we are looking at. Even in a high reserve, definitely we are looking at a lower dose, and in a low reserve also softer protocols are what we are looking at. Let me explain to you in another way, especially now for before COVID days, we used to talk a lot about cumulative pregnancy rates, and that is where we used to say that, okay, optimum number of oocytes should be there, because we were talking about one and done approach, and one and done approach was that in one pickup you do at least 2 or 3 embryo transfers and the patient has at least 1 or 2 babies and the family is complete. Now today, if we have to freeze embryos, we have to think now. And when we have to think, and especially if the patient, you are overstimulating the patient, then also you have to think, because hyperstimulation is a big no, because peritoneal fluid is harboring these COVID coronavirus. And just yesterday there is a publication in the Lancet which says that if we are doing surgeries or if we are doing any kind of intervention in the abdomen, the mortality and the morbidity rates of these patients are very, very high. So this is something which we really have to avoid. So probably right now we should not be thinking about too much about cumulative pregnancy rates. We should be thinking about getting the patient pregnant in the first go, which will need a very nice physiological atmosphere. But if you have extra embryos, yes, freeze them in a separate cryocan, which is important. So this is what normally for a live birth per fresh embryo transfer is the number of oocytes, which various studies have told us. So we are not looking at anything here. We are only looking at between 10 to 15, which can be very easily managed. But what am I looking at? Because I know that today is the best time for us to minimize the interaction, not only with the patient, but minimize the interaction with the staff in the lab also. So we are today right now propagating that the time-lapse system is the one which is important right now, and plus blastocyst is what we should be transferring. So that is an ideal place and time to achieve the best outcome. So now let us calculate in a different way the number of oocytes which are required to obtain a blastocyst according to maternal age. Now these are all based on, let's say the patient is 35 years. We know that at 35, less than 35, the euploidy rate is about 60%. And you need at least about 2 blastocysts for a good pregnancy rate. You can transfer 1, you can freeze 1, it's up to you, but you have an optimum 2 blastocysts. For that you need, if you have a very good lab, you need about 4 fertilized eggs and 5 M2 oocytes. And if you have a good protocol, you will need only 6 COCs. In a patient now, how much dose is required to produce 6 COCs in a normal responder? You can understand very well. Now, if you have a patient within the age of 39 to 40, we understand the euploidy rates are going to be 30%. Now, you need about 3 blastocysts because you know one is going to be abnormal, 6 fertilized eggs, about 8 M2 oocytes, and about 10 COCs. And similarly, for older age group, I know that this in our scenario, most of us will offer donor oocytes for this age group, but donor oocytes or donor cycles are not actually being recommended by ESHRE or IFS statement. And plus, it will again have a lot of added cost on basically investigating the donor, especially for COVID and other things, and plus keeping the donor somewhere safe, not exposed to corona. So we need to again weigh all those costs also when we are deciding. Let's come to poor responders. Now, these are ESHRE guidelines for poor responders, and I would just enumerate a few. GnRH antagonists and agonists are equally recommended for predicted poor responders. So you could do both, but if you see the grade of evidence, conditional. Clomiphene citrate alone or in combination with gonadotropins alone is equally recommended for predicted poor responders. Strong. Now, this is something which we need to understand, and I'm going to come to this a little later. Addition of letrozole to gonadotropin in stimulation protocol is probably not recommended for predicted poor responders. Again, conditional. There are places where you can still apply. It is unclear whether higher gonadotropin dose is recommended over 150 units. Again, you have to understand that higher dose is not really going to help unless and until you have had a poor responder who did not respond to a lower dose before you can go for a higher dose. A gonadotropin dose higher than 300 is also not recommended because it doesn't really improve the outcome. Use of modified natural cycle is probably not recommended over conventional, and no studies are found comparing reduced FSH dose to conventional stimulation protocols. This is my slide, which has been there for, I think, more than 15 or 20 years. And only thing we Indians, we don't publish. And that is our major drawback. And if you see here, either whether it's IUI or IVF, depending upon the response, or you could actually start with clomiphene starting from day 2 to day 6, add about 150 units of HMG or REC-FSH, depending upon, again, the patient profile, add antagonist, and then you're ready for pickup. And this, now, if you are weighing with the patient and you're trying to tell the patient that if you turn COVID positive tomorrow, I will cancel the cycle, which cycle would you like to cancel? This cycle where you have not spent even 5,000-6,000 rupees or 7,000 rupees on the stimulation protocol, or a cycle where you have spent 50,000 on the protocol. Now we need to understand, and that's where we need to apply. So because only reading in the books is not going to help. Second important thing, whenever we do antagonist cycle, and especially for poor responders, the major problem which arises is the asynchronicity of the follicles. Like if you see here, all of them are different size. So you have different protocols which are available to you, especially the one which is today used by many of us, that we do some priming by estradiol, about 4 milligrams you can give every day, starting from day 1 to day 5, and or maybe a little longer also, and then start stimulation whenever you are ready. And that will definitely improve the synchronicity of the follicles, and the outcome in a pre-primed cycle and a not primed cycle will definitely be between 2 to 3 M2 oocytes, and that's a huge number as when poor responders are concerned. You can modify it a little further also by estrogen priming, and then you can give antagonists for a few days. Now this can be done, especially supposing the patient is from outside, cannot come, and need some more time. Pharmacies are all open, drugs are all available. You can just tell them, okay, can you please, start this and then come whenever you are able to come. And this protocol, again, if you see, the oocyte retrieval in poor responders definitely improves. So I have just summarized all this in this very busy slide, just to say that yes, milder stimulation protocols in combination with low dose gonadotropins are probably the best ones, and plus a lot of innovations are available to us where you can improve the optimum oocytes and recovery from the patient. I'm coming to dual stimulation, which we used to talk a lot, because dual stimulation is right now being used either for poor responders or for people who have to go for fertility preservation. And this is again a stimulation protocol which can be utilized. Let us say that like a patient is stuck with me now, has come from abroad, and she cannot go back. I have to do whatever best can be done. And if she turns out to be have a poor response in the first cycle itself, I can immediately start a dual second stimulation after the pickup. Now, all that, if we know and if we have a mind to apply, can very easily be done. And these are just studies to tell you that there has been absolutely not much difference as far as when you compare the follicular stimulation protocol or a luteal phase protocol. And the results also have been pretty much good. Next is any day start protocol. Normally, I'm going to come to the guidelines where people, ESHRE and others are saying, no, not recommended, but you might still have an occasion where the patient has just come in and cannot go back. What best can you do? You can start any day. You can actually start any day of the follicular phase or the luteal phase and have an optimum result in these cycles. And that is something, again, we can think of. So I'm just going to go and, just read a little bit of the ESHRE guidelines, which have come on the 1st of May. Random start ovarian stimulation is probably not recommended for general IVF and ICSI population. We have to understand for general. So we have to read every word, and the grading is conditional. Late luteal phase start of gonadotropin is probably not recommended for poor responders, again conditional. Early luteal phase start for gonadotropins is not recommended for normal or poor responders, again conditional. Late luteal phase stimulation could be used for non-transfer cycles. Double stimulation in poor responders should only be used in context of clinical research. That is something which they have come up with. And also double stimulation can be considered for urgent fertility preservation cycles. So we read and we apply what is applicable to our own situations, which is something which we have to understand. Lastly, I'm going to come to hyperresponders. Now, hyperresponders are PCOs. I would say if they are obese PCOs, we already know that the outcome of these PCOs, they can get pregnant. That's not a problem. But with a high BMI, the miscarriage rates and the clinical pregnancy rates are lower. And also the chances of having all kinds of NCDs in these patients are going to be also higher, especially in their babies. And so it's a very good opportunity for us to counsel them that please try and exercise and reduce some weight. In these 2-3 months of lockdown, concentrate on your health, and then we will take you up as soon as, and losing about 5-7 kilos is going to definitely help you in your outcome. Now, patients who have been already waiting and have, are obese and PCOs and maybe of advanced age group, here is a study which, helps us in saying that, yes, if you're not reducing weight or you can't wait for much longer, then there is not much difference as far as the pregnancy rates are concerned. But I would still say that getting a patient pregnant is not the only thing. You need to have a healthy future progeny, which is very, very important. And that is what we should aim at. And that is why a little weight reduction and exercise is important for all of them. Now, individualization, which we have already said. Now, in this era, this is a wonderful article by Frank, which says that, recent controlled ovarian stimulation protocols using GnRH agonist trigger for final maturation. Now, what are we scared of in hyperresponders is a OHSS. Now, if we keep the dose down and if we give an agonist trigger, we have taken care of it. So I don't see any reason why we should be really worried about. And lastly, if we do segmentation and if we have counseled the patient well, then this protocol for patients who inadvertently will still, in spite of all your efforts, have gone into more than 15 oocyte retrieval, then yes, all freeze is something which is mandatory and should be done because you cannot take risk. Last two slides on back-end logistics, very, very important. Your emergency plans have to be in place. Your supplies should not be falling short, especially gases, media, and all those things. You should prevent all unintended exposure to the staff and for the risk of COVID. And in particular, the whole team has to have, you divide your teams into at least two parts so that you have, if one team has some exposure, then the other team takes over and work does not stop. You'll need some extra clinical and psychological counseling support for patients also. Teleconsultation is the best. And avoiding, the feeling of uncertainty in patients, teleconsultation again is a must. And last, smart management inside out. It's not only the smart protocols which you're going to use, it is also the judicious use of mind and technology. This is the time at which point of time electronic witnessing system, you don't have people to do double witnessing, so electronic witness system is going to help. Time lapse is going to help because you just keep the dish and come back and see it after 5 days and that's it. So you don't really need people coming in every day to keep a check. You can check them on your phone also because they're all connected to our system. Automatic filling of the liquid nitrogen tanks, again, very, very important. And automated storage of samples in the storage tank. Now, these are the things which are actually not the future, they are actually required today. And I'm so happy that we have everything in our lab and we have actually been very, very relaxed in this COVID time. So I'd like to thank each and every one of you. I would say think positive. The mindsets and the systems, need some reorganization, and that is the dictum of the time. And all the best. I am sure the future is very, very bright for all of us. Thank you.
Thank you, Dr. Jaideep, for that wonderful presentation. And again, just reminding our viewers, if you have any questions, please put them in the chat bar, and all of us are going to be on the chat column and we're going to try and actually answer them. Dr. Jaideep, if you can just stop the screen share, then I can start my presentation. I'm going to be basically focusing on the lab aspect of the management. I'm only going to talk about cost effectiveness and how we can actually reduce the costs in the laboratory, though most of my presentation is actually going to increase costs. So sorry for that, but I'm going to try and explain to you how we can actually reduce costs in the management itself. Okay, so if we had actually talked about the fertility business, maybe a few months ago, maybe if it was December or even November, this was the article that came out in Seed Capital, and it actually said that the Indian fertility business is booming. But if you consider the scenario now, if we get back, so if I talk about next December, and if we get back to even 30% of what we were doing in the last December, it would actually be a huge achievement for the clinic. And that's the kind of scenario that all of us are facing. We're facing a huge downturn in the number of cases that we are doing, because for the last 3 months, we've actually been shut. There are no cases which are happening. And it's a major cost burden on the patients. It's a major cost burden on the clinic. It's a major cost burden on the corporate chains, which are also working at the moment. And that's why we really have to now start thinking out of the box. And we don't have to now think of just reducing the costs, because when we think about reducing the cost, the quality of care also declines. So we have to find a balance between the quality of care and the cost of care. So this was a survey which I could actually find. This is a recent survey which was actually talking about what patients consider as far as the outcomes are concerned, and they basically look at the experience of the doctor. They look at the type of center that you're affiliated to, the technology in the laboratories, the success rates, etc., etc. Cost is also a major factor here, but there are so many other important factors which we also have to consider. Now, if I look at the costs of the cycle and across the countries, India stands somewhere around $2,000 per cycle cost, and this has been published in Lancet as well. And now we want to now think of this $2,000 and now think of not increasing the cost too much for the patient, and maybe even think of reducing the cost so that we can actually offer quality care without actually minimizing the risk to our personnel which is working in the laboratory. So when I talk about COVID times, there is a certain increase in cost that we all are projecting. And this increase in costs can be because of the PPE that has to be provided to all staff, all doctors, and even to the patients as well. It can be attributed to the increase in the disinfection because we now have to be very, very stringent. It also can be attributed to our staff because we obviously, if you have certain amount of staff in your clinic, this is the time where you want to utilize them. You don't want to chuck them out. You don't want to like cut their salaries, etc. But again, that's going to be an added burden to your working. We also want to think about AMCs. We want to think about new procurements because those are the ones which can actually help us in managing this situation much better. And lastly, the increase in cost can also be because of the disposables, the medias, and again, I'm going to talk about effective management of all of these scenarios. Now, the first thing that we have to consider here is that PPE is essential. Now, even when I talk about the embryology laboratory and the embryology laboratory being the least infective or the least of the transmissible areas in the hospital, we still have to ensure that PPE is given to all the embryology staff that's working in the laboratory. And this PPE includes basically the full body covers, gloves, mask, eye covers, face shields, and even shoe covers. And all of this has to be provided because we're now dealing with semen samples, we're dealing with follicular fluid, and again, we're also dealing with contact because the doctor is going to hand over the tubes or the nurse is going to hand over the tubes, etc., etc. So there's a lot of high contact surfaces which are present in the embryology laboratory itself. And all of these can be major risk factors for COVID. So that is one of the reasons why PPE is essential. And this PPE has to be probably changed every single day. So that's one of the major burdens. So if you think about effective management of PPE, there are some gowns which are available which are autoclavable, so you can actually reuse those gowns. The N95 masks, again, there is a lot of debate on whether to actually sterilize them or to replace them, but because there is a huge shortage, most of us are moving towards trying to reuse the N95 masks as well. So you can actually try and clean them up and try and reuse them, because again, if I want to emphasize here, the embryology lab is the least infective of all of the scenarios that you are actually going to see in an IVF unit. And that is why most of the times these consumables can actually be reused, and in that way you can actually prevent most of the cost implications that are associated with PPEs. Disinfection is again very, very important, and the right disinfection is very important in this scenario, and frequent disinfection is very important in this scenario. So I've actually recorded a few videos of disinfection which I'm going to be sharing on my YouTube channel. This is just a small clipping of it, and we're going to demonstrate how to actually clean all of the surfaces, etc. So you can actually go on to the Meta YouTube channel, and this should be live tonight. But what I want to mention here is that you have to think of using IVF safe disinfectants, because that is something which is very, very important as far as the embryo quality and the gamete quality is concerned. So do invest in using IVF safe or VOC free disinfectants. And these disinfectants are in the form of quaternary ammonium compounds, which you can actually use for your surfaces, incubators, floors, walls, etc. And they can actually help you in getting rid of any kind of viral particles within 10 minutes of exposure. So the most important part here is that 10-minute exposure which has to be provided. Now, the most important thing that we have to now think about as far as the IVF scenario is concerned is the staffing of the laboratory. And I've tried to take out some of the excerpts from this article, which is the Italian perspective on managing IVF laboratories in pandemic situations, because they've already gone through the whole pandemic, and now we are probably facing the same kind of scenario which is happening in Italy. So the most important thing that we have to consider is that we have to now ensure that we make mini teams in the laboratory, and Dr. Jaideep has also emphasized on it. So try and divide your staff into at least 2 teams, so that if one team is exposed, the other team is ready to actually come to work, and you don't lose out on precious practice. Again, very important is that in this scenario, if you're maintaining, like I was seeing a few questions which were there, if you're maintaining proper disinfection, if you're maintaining proper PPE, then there is a very high possibility that even if there is a COVID patient that comes into your clinic, the clinic will not be sealed. You might only be required to shut down for 24 hours so that you have a proper disinfection of the surfaces, and that's pretty much it. You can actually start work immediately after that. But your team, which might be exposed, might need to be quarantined, and that is one of the reasons why dividing your teams is very essential. So in this particular scenario, try and divide your staff into at least 2 teams. We are lucky that we have about 4 embryologists in the clinic, and we have 4 clinicians in the clinic as well. So we can actually form 4 teams, and with the electronic witnessing system, we don't really need a second embryologist in the laboratory to document it. So these are things that you have to think about. Obviously, whoever's coming into the laboratory is going to take universal precautions. I'm not going to emphasize upon it, but this is something that I wanted to emphasize, and this is basically coming from all units which are also handling HIV cases. So I'm just taking that example in this scenario as well. So what these people have done is that they've actually divided their laboratory into 2 components. One set of equipments is actually dedicated to managing high risk cases, and the other set of equipment is actually dedicated to managing low risk cases. And this is something that can be implemented if you have a slightly larger laboratory. You don't need to create partitions, you just need to create separate spaces within the same laboratory. Just dedicate separate equipment for your suspicious patients and your triage negative patients, and in that way you can actually be managing these patients much better. Now, this is again just an example which I could take out from that paper, where it's the same laboratory, but they've actually divided it into 2. One part handles the normal cases, one part handles the suspicious cases. And similarly, you can actually think of managing your cryocans as well. So you need to have proper dedicated cryotanks in this particular pandemic scenario, because we don't know yet. We have no literature on it. We don't know whether the virus will actually survive, cross transmit, cross infect. We have no clue. But the only thing that we can do at the moment is be careful, and these are things that can be implemented in the laboratory. And obviously this is an added cost, because you will need multiple cryotanks in your laboratory, multiple gas cylinders for your incubators, and I've already spoken about the alarm systems and how to manage cryotanks effectively, so I'm not going to go into that detail. I think Shivani can actually share that webinar with all of you as well. But these are the places where costs are going to rise, and this is where effective management is needed. Now, a good solution in this scenario is actually trying to implement closed system vitrification, and that's something that can be offered to your patients, and it's a very safe system. It can actually prevent any kind of cross contamination. And again, if you don't have those separate cryotanks in your unit, this is something that can be easily implemented. Most of the embryos, it's the same technique. The only added step here is to just put the sleeve in another sleeve and just seal it. That's the only added step. It will not require much training, and this is something that you should be thinking about. Now, very important here is controlling the air quality within the laboratory. And I was actually having a discussion yesterday with David and Sharon Mortimer about air quality in the laboratories. And it's very important that you have these air exchanges in place. Now, if you don't have an air handling unit in the laboratory, it's probably not the best kind of scenario for you to be restarting your IVF practices at the moment, because we know that if there is stagnation of air within the laboratory, and with the new data that's coming in where it says that this virus can be airborne, this air handling unit, especially with an HVAC system, possibly if you have a photocatalytic system in place inside this HVAC system, is the best way to eliminate the virus from your filters, from your air streams. And it's actually one of the easiest ways to actually decontaminate the laboratory. And that's something which again might be an added cost. We've already spoken about time lapse and its efficacy in this scenario, where this can be used to minimize the contact between the dishes, can be used for safely monitoring the dishes without embryologists coming into the laboratory. So work from home scenarios can actually be implemented using these technologies. But again, all of these technologies come at an added cost. Again, the witnessing systems that are available, we are lucky that we have all of these technologies in our laboratory. But for an upcoming laboratory, for a smaller laboratory, it's not the easiest thing to do. And that is why the probably the only place where you can actually think of reducing or managing your costs more effectively is the disposables and the medias that are coming in. So when I talk about disposables, there is a lot of cost that is associated with disposables. You obviously have an inventory cost, you have procurements, wastage is there, pilferage is there, expiries are there. And these are things that we generally in a normal IVF unit we probably bypass these scenarios, because okay let's 4-5 dish waste ho gayi, we would not bother about it that much. But now when we're thinking about COVID times, where our overhead costs have increased so much, we have to look at certain scenarios where we can actually reduce the cost. And this is one place where you can think of reducing costs. So this was one of the kits which I actually came across in the last ISAR. I think that's when they were launching it. And these are individualized kits for your patients. So now you don't need to buy in bulk. You can actually, if you have one case, you just buy one kit, and that has sufficient amount of consumables for one patient. And again, that's one of the ways to actually manage your consumables in a much better way. And this is not just for your OPUs, it's available for all of the kind of procedures that you're doing in the laboratory. So ICSI, OD cycles, thaw cycles, etc., etc. These are specifically dedicated consumables which are available for per patient. And they're actually manufactured, they're not manufactured, it's a repackaging process which is happening in India, where they've actually set up a state of the art laboratory in Mumbai. And they're using all kinds of precautions in repackaging the kind of consumables that you want to use, so it's customizable. And in that way you can actually use the same kind of disposables that you use in your laboratory, but in limited quantities. And that's something that you can think about. Now the second part of this is managing the medias. Now this is also very important, because most of us buy medias in bulk, because there are offers on medias. If you buy 5 bottles you get one free, etc. Now these situations might not be the best in these times, because media is something that has an expiry to it. And most of the media companies have short expiries. The maximum expiry date is probably 1.5 months. And even for a smaller unit to finish 10 ml in 1.5 month might be challenging in this situation. So again, I would want you to restrict on the amount of media that you're buying. Obviously have certain amount of surplus in case of emergency situations, like if you have a contamination which has happened, or there is some mishandling of the media, etc. So some backup media should be there in your laboratory. But try and buy small volumes, try and buy more frequently, instead of actually keeping it in store, because you have to worry about the expiry of the media as well. So when I think about media, try and buy the longest expiry media. There are a lot of medias which are available in the market. I've tried all of them. There is probably no difference between any of these medias. But the things that we have to consider now is that we want to look at the expiry date of these medias. We want to look at the packaging of these medias. So smaller bottles is something that we would want to recommend here. We want to look at the distribution network of these companies, because if they don't have a good distribution network, if they don't have large number of distributors, then the cold chain management of these medias can be broken, especially in this pandemic situation. And that's also something that we should be considering. So again, look at all of these factors and try and develop a good relationship with your supplier, so that in case there is a media which expires, again, Ashish ji, if my media expires, probably you will be able to help me in replacing those bottles, hopefully. So these are the kind of replacements or the relationships that you want to develop with your suppliers. Obviously, we want to look at single suppliers and single person handling the medias and the consumables at this moment, because the less amount of hands, the less amount of transmission that happens in your laboratory, the less amount of cost that comes to you. So you don't have to worry about paying extra charges for couriers, distributors, etc. So try and explore these options, and these are things that can actually help you in minimizing the cost. Now obviously, there are other management strategies that we have to think about. Now work from home is something that I would personally want to advocate, even for embryology. Now we all feel that embryology is something which is very hands-on, which is where we all needed in the laboratory at all times. But if you look at the maximum amount of time which is spent by an embryologist, it's basically on documentation, it's basically on auditing, quality control, etc., etc. And these are things that can happen from home. So if you have online systems in place, if you have EMRs, etc., which are in place, this documentation, this auditing, this filling of your records, etc., all of these jobs can happen online. And this is again one strategy where you can utilize your mini teams. So if one team is working in the laboratory for 1 week, the other team can be doing all of these jobs of documentation, reporting, etc., creating the embryology reports. Again, these are things which can help you in utilizing your staff. Your staff also feels occupied, you're paying your staff, so they have to do the work for you. So these are things again you should be thinking about. Cost effective management of PPE and consumables medias I've already spoken about. Now one particular scenario which is very problematic in this situation is batch IVF, and that's going to be a major challenge for most of us who are here at the moment. Now we have to think out of the box in this particular scenario as well, because batching of patients might not be the best kind of policy for IVF clinics at the moment. Instead of batching, we really need to think about spacing of our patients. And the ideal time between ovum pickups at the moment has been set to be 1.5 hours. So even if you're thinking about batches, they have to be done in very small batches, has to be spaced very well, so that patients don't come into contact with each other. So at this particular scenario, it is a possibility that you should be thinking about developing relationships with bigger IVF centers, so that you can probably stimulate your patients and send them to only one particular laboratory which is handling these cases. And that's also something that should be thought about, because managing costs for a running laboratory for a smaller center is very difficult. You have to think of so many overheads. And if a center is already running a laboratory, is already managing such kind of patients, and you only have 2 or 3 patients a month, you can obviously do the stimulation yourself and utilize just one laboratory for these cases. So that's something that you should be probably exploring. Another option that you should be exploring is to try and reduce the financial burdens. Now, most of us usually dispatch the consumables from the IVF clinic itself. There is an option where you can actually ask the patient to buy these consumables from the pharmacy. So get these available in the pharmacy. So what will happen is that if you have these one-off kits which are available, which are per patient, you can just tell, okay, this is my added cost, this is my professional fee which I'm charging for the laboratory and the embryology staff, etc., etc. All of these other things, the drugs will come from the pharmacy, the consumables will come from the pharmacy, etc., etc. So when the patient comes to you, your cost is only, let's say, 25,000. The other costs which are associated with IVF, obviously you have to counsel the patient for it, but the patient does not have to pay to your clinic. And that's where you might actually benefit in your counseling, and you might actually not have patient fallout which might occur. So this is again an option that you can consider. And especially when you're selling this from the pharmacy, you will also save on GST, which also is an important factor to consider at this present moment. Now, again, one more very important scenario is reducing the running costs, especially if you have a big laboratory like we have in Agra. Half of my equipment is shut at the moment, so that I'm saving on gas supplies, I'm saving on electricity, And I'm also saving on manpower. I don't want people to be walking into my lab, cleaning all of those equipments on multiple days, increasing the risk of exposure, etc. So this is again something that you should be considering. So if your lab is not working at the moment, and if you've actually spaced your patients well, shut down your equipment, start it again about 4 days to 5 days prior to the cycle, do your sterilization process, etc., calibrations, and then use it for your cycles. And again, once the embryo transfer is done, you can shut it off again. This is in lieu of actually saving on the gas supplies, because at this moment, especially when the borders are sealed in smaller cities, like I'm also suffering from not getting access to tri-gas at the current scenario, and we are trying to manage it as effectively as possible. But because the Agra Delhi border is sealed, I'm waiting for the lockdown restrictions to go down. So these are things that you have to now think about, and probably reducing running costs is the most important parameter to consider in order to actually offer cost effective solutions to your patients. Last thing, reduce on wastage, because that's one of the most important things that happens in the laboratory, especially the medias that are there in the laboratory. So try and calculate the amount of media that is required for your patients for that 1.5 month period. It is going to be a little difficult, but you have to do your calculations well, and try and actually use only the required sufficient quantities of medias and consumables for your patients, so that you're able to offer IVF in a cost effective way. Because again, like I'm mentioning to you, there is an increase in cost which is going to happen because of the PPEs, because of the disinfection, etc., that is going to increase per patient. And if you reduce on your wastage, you probably can offer IVF at the same cost that you were offering before COVID happened. So that's something that we should be thinking about. Obviously, most parents are going to say that their child is priceless, but that doesn't mean having one is cheap. And it's our job as responsible clinicians to offer cost effective solutions, especially in developing countries, because that's where the whole access to IVF or access to ART actually lies. And cost effectiveness is very, very important for our country as well as for the developing world. So thank you so much for attending this very innovative webinar. All thanks to Intas and Shivani Scientific for actually hosting all four of us, and allowing all four of us to speak on a common platform. And I think we can take in a few questions now. All right. Okay, so I'm going to go back to a few questions which were there. So the first thing that we have to talk about is the management of the male patient. The management of the male patient, and there are a lot of questions that were there for how to actually manage male patients. So do we actually advise ultrasounds for all of these patients, or do we just move forward without actually doing ultrasounds? So your take on Dr. Jaideep, Dr. Narendra, on doing scrotal ultrasounds or transrectal ultrasounds? Yes, Dad.
For a male, basic is semen analysis and testicular size or examination. Now, if you have good motile sperms, which you see on the slide, then no further investigation is required. And if you have a low volume ejaculate, or if you have azoospermia, if you have oligos, or if you have any other abnormal, then it is classified then endocrine profile is needed. And then an ultrasound scrotal and truss. There are 3 types of ultrasound which will be done. So all patients do not need an ultrasound, only a palpation for testicular size. And then anyone can see, if you don't have an andrologist and you are females and you are hesitant, then you have those beads, the testicular size beads. And one of your technician can just match the size of the testes with that bead. So that's how simple it is too. Of course, for varicocele and all, you need a andrologist or a urologist to examine, or if you're trained for examining that, then that you need.
Now, another
if you have good motile sperms, No further tests.
Another common question, which I think a lot of people are asking at this very moment, is about semen analysis itself. Should we be doing semen analysis in the laboratory? Should we be doing it in the pathology? How many times should we be doing it? Should we be freezing samples? Dr. Jaideep, your take on it, and then I'll put my comments.
Keshav, I think in our lab, all of us had decided that because we are into now teleconsultation, so once the patient, takes an appointment, we tell the patient that please get and quite a few of them are coming from outside also, get the initial semen analysis done at a good pathology which is available near you. And that's very important in the sense that saves the trouble of our IVF team getting exposed. These pathologies who are already doing, they are taking all precautions, and all what you require is a good report. And if you have a good report, fine. If you have any other issues, let's say if the report has, the counts are not good, or the motility is not good, or you need an evaluation to be done in your own lab, then you can do it. So this will reduce the load, plus it will also reduce the issues with the patient, coming just for a semen analysis.
Yeah. And again, like even if you're thinking of doing semen analysis in your own center, following proper disinfection is something which is very important. And again, if you space your patients adequately, take that 1.5 hour period that we are doing for the OPUs as the same period for your semen collections as well. You can think of putting a UV light inside the semen collection room to disinfect, because obviously it has less amount of exposure. Be very careful that once the patient is giving sample, that UV light should be off. So the control of the UV should be in the hands of the embryologist or the lab staff. These are certain things that you can think about. Yes, Dr. Jaideep.
Keshav, I still feel that whatever you may do, because if you're going to take all these precautions, it's going to add up on your cost.
Yes.
And semen analysis, most of the people are not charging as much. So, and then, for just 5-10 samples, not even that, I don't know how many labs, IVF labs are doing as many. The costs are too high. Supposing you have no pickup in the lab today, you have only one semen analysis, PPE kit, sterilization of or fogging of the semen collection room, of the staff. I feel this is a time where sharing is very important. Mindset change for us doctors, that सब कुछ मेरे को ही करना है, वो नहीं होना चाहिए. Please share the responsibilities. Even share your clinics. I would say that there are 10 clinics in the city which are available. You could say, okay, semen analysis एक जगह पे करेंगे, या इस महीने pickup एक जगह करेंगे. So that will also cut down on your cost. Plus, it will reduce the exposure of the personnel. It will reduce, wastage of the media, consumables, and everything. So we need to now think of bringing people together for the best, which is very, very important.
Okay, Neharika, there is a question on the testing that we need to advise.
So
how many tests should we be doing, and how often? And we've talked about OPU patients. What about FET cycles? What about OD cycles if that happens in the laboratory, etc.?
Someone is asked, what about before semen analysis?
So we have to actually understand is that even if I do a test today, the patient can get positive tomorrow. So we have to understand that how many times we would like to do a test. It is your personal choice. The first important thing is triaging. So if you do a good triaging system in your hospital and you know that the patient has no risk factors, maybe just one test before, like on the day of HCG trigger, or just when you start progesterone for your embryo transfer is enough. But if you know that when you would like to cancel a cycle and this patient might create some issues, you might like to do a test a little before. But then we also have to understand that once we do this test, after that the patient has to take all precautions like isolate in their homes, do not go outside, proper social distancing and mask, so that they do not come in contact and they do not get any risk for COVID after getting a test done. So in our center, a protocol is followed is we like to do a COVID test on the day of progesterone for a frozen embryo cycle, or on the day of HCG if we are planning a stimulation. So that's what we are actually following, so that we also balance the cost of the test with our cycles.
And also for frozen embryo transfers, we are only doing it once.
Yeah, once.
The day we start the progesterone.
Yeah. And obviously advice for maintaining social distancing, isolation, etc. have to be given to the patient. Minimizing that contact has to be told to them in order to ensure that we are also safe and the patient is also safe. Yes, Neharika.
Second thing also I saw in the chat box was that the cost of the test. But now the district hospitals are also collecting the samples every day from hospitals, and they're doing it for free. So if you book your patient a day prior with the district hospitals of your cities, then the test might be free. So you can also cut down the cost of the test there.
Yeah. Okay. So yes, that.
What about the antibody test, Dr. Neharika? ESHRE guidelines, some clinics just said that every patient they do a test, antibody test when they come there only. And then
I actually had those things on my slides. I removed them. Now, antibody test for the patient, definitely. I mean, if let's say if it is positive, you still don't know because reinfections are also there. A lot of people in the world are using, especially China and other countries, are using it for their staff. The staff who is antibody positive, they can just bring in them to work, especially in high risk areas. Because that is where the exposure is the maximum. But otherwise, antibody test in our country is not available. That's why I removed them. And it's not very dependable.
Okay, Amit Bhatnagar is here. He's asking about, do you actually suspect that IVF costs are going to rise once we resume practices, or can we actually control them?
So the whole today's topic was about how to cut down the cost. And if we follow all these steps, so I don't think we'll see a rise in the IVF cost. We might be at the same level as what we were charging before, is what I feel.
Yeah.
Okay.
See, it's how smartly you organize yourself according to the infrastructure and the things which are available to you. Like as Neharika was just saying, like in Agra especially, that we know that the COVID testing is free. You have to just book yourself, a day or 2 days before. So it's a little unpredictable, but it's there. So you could actually cut down on the COVID testing totally, but don't misuse it. You can't do it for everyone. We have already started in the beginning only, which are the patients for whom you will do IVF.
Yeah.
You're not doing it for everyone right now. So the ones who are really in need, those are the ones you choose, and those are the ones where you can cut down on the cost. Secondly, second cost cutting, you can very smartly do with a lot of things which we have discussed and protocols.
Yeah.
Because and the patient doesn't understand cumulative pregnancy rates or something. Patient only understands what the patient is spending right now. So if we have not increased that cost, and if even in spite of not increasing that cost, you've gotten some embryos to freeze, the patient will very nicely pay for it. So I think the strategies have to be in place.
Okay, so there is another question which basically suggests AC should not be used in COVID times. How do you manage temperature in laboratories, etc.? I think I'll take that. What we have to understand here, Dr. Sanjeev Khurd, is that the air circulation and the number of air exchanges in the laboratory have to be maintained. So even if you have your ACs which are on, if you have fresh air which is ventilating inside using your AHUs, etc., and if you have about 14 to 16 air exchanges which are happening per hour, that's something that is recommended, and that will look after the quality of air inside your laboratory, and you should not be worried about the virus actually going through your filters. Another thing, if you're very, very worried in this particular scenario, is that you can think of adding a photocatalytic system for your laboratory, and this photocatalytic system is actually kills the virus, deactivates the virus, and those are again certain additional components which could be added in this present scenario. The most important factor here as far as air conditioning is concerned is that IVF units should have separate dedicated air handling units, should not have the ACs within, which are actually centralized for the whole hospital, etc. So that's something that should be there for the IVF laboratory. All right. Let me look at one or two more questions. Again, male patient also has to be tested before giving the sample. Your comments on that?
See what the recent studies have come up, and there's only one study from China which has said that about 16% of the samples. Now, those samples also have come positive in patients who have had active disease. So
Yeah.
I feel that, if you have to spend on the patient for COVID testing, you can very well nicely triage, and if the patient is, the husband is totally asymptomatic and has had no problems at all, I don't see any reason to do that.
Okay, awesome. So I think we are at the end of this webinar. I'll just like all the speakers to just give like a few take-home messages. Dr. Naren, we'll start with you and we'll move forward in the same sequence.
So don't be afraid of Corona. Corona is here to stay. This is another virus which we'll have to live forever till the vaccine comes. And vaccine is not coming for a year at least. And to India, it might be a little later, though some company has today in the newspaper declared that they'll get it in India in October. I'm not sure of that. Even the drug, the antiviral drug, is going to take another 6 months. So, but after 6 months, we will have weapons to battle this disease, and it will be just like a disease, just like tuberculosis, hepatitis, HIV. HIV is more dangerous, and so we have to live with it. So be brave, take precautions. The only problem which is mankind is going to face is social distancing. We are not used to social distancing. We are used to hugging each other, kissing each other, and we are used to shaking hands and everything. So that's what we're going to miss. All the best.
Neharika?
I would like to just say that we know that the dilemma of starting an ART service fully now at this stage is very, very genuine, and at every step you are going to face a little bit of difficulties, and so many guidelines from all over the countries are coming, but we have to also understand that every country will actually follow a different recovery curve because it depends on their resources and the cases happening in their country. So we cannot just rely that, oh, the ESHRE guideline says this and we have to just follow it line by line. We also have to understand what is happening in our country and in our own setup. Most important thing will be a personal protection equipment, a social distancing, and also limiting the number of cases. So only do those cases which are actually genuinely need IVF and which cannot be postponed.
Thank you. Mom?
I feel that this is our best chance to change our practices, change our protocols, and also have a quality, ethics, and dignity for all of us in place, which is very, very important. And that will only come up when we'll have the right kind of practices and protocols in place. So and plus very, very important is teamwork, cumulative practices, and cooperation to each other. And that's, and I won't forget Modi ji, Make in India, because when you're looking at, reducing the cost, everything, whatever we use in ART is indigenously available, whether it is disposables or equipment or our gonadotropins. Here are these two companies which we are really working with, all Make in India, gonadotropins also and consumables also, incubators, witnessing systems. What more do you want? Why should you pay extra for something which is very nice and available in India, made in India?
Yeah. And my last comment here would be just to follow up on what Mom just said, explore your options, because there are so many things which are available in order to reduce the cost towards the patient. Explore your options, explore your relationships with the companies, with other centers which are there in the city, etc., and try to cumulatively work towards actually reducing the cost towards the patient so that the access to the infertile couple doesn't actually get hampered. So with this, thank you so much. I know we've missed a few questions, but I'm sure we're going to take them up on email.
Keshav, I will come in.
Yes.
Yeah. So first of all, I will thank you to all the participants for spending their valuable time on Sunday and the speakers for giving a very informative lectures. And also special thanks to Shivani and Intas team for promoting this event. And also thanks to Mr. Sumit and his team for hosting this seminar. So as we had always said in lockdown that stay home, stay safe. Now we'll have to adopt a new slogan, go out and be safe. and wish you all of you very happy and safe unlockdown. And thank you very much.
Thank you.
Thank you. Yeah, thank you.
Thank you, everyone. God bless
Thank
you.
you, everyone.
Thank you.
Stay safe.
Keshav, are we doing the group photo?
Yeah, we
Yeah,
can
let's do
a
the group photo. Yeah,
Okay, I
Mr.
want
Sarpati, Ashish, please stay back. And Sumit,
Sumit, please be online.
We are going to have a group photo, so please be online.
Cameras, please. Everybody need
I want everyone to please switch on their cameras. Give us a big smile. We are quite a lot of us, so it's going to take some time. So you want to hold that smile for a longer duration. So do switch on your cameras. We're going to do the group photo. I'm going to take screenshots of it. Sumit, whenever you're ready, just give us a countdown. Okay, guys. 3, 2, 1. Okay, there are 6 pages, so I'm going to do 3, 2, 1 again for those 6 pages. So again, 3, 2, 1, guys. Big smile. A lot of people have still not switched on their cameras. Awesome. So thank you so much, everyone, for such an interactive webinar. I think all of us had a great time. Thank you for sparing so much time. And
so go out and be safe.
Yes, go out and be safe. Take all the precautions, and we will win this battle against COVID.
Thank you, Dr. Keshav.
Thank you. Thank you.
thank you.